Hey guys, how are all of you doing? So today we are going to cover the most important topics in ortho for the upcoming November INI. So moving ahead with the questions that we have here. The first question is saying that an elderly man presents with acute pain and swelling in the knee joint. The synovial fluid aspirate is examined under the polarized light microscopy and shows positively birefringent rhomboid shaped crystals. So here the most likely diagnosis, we have only two differential diagnoses here since it is talking about synovial fluid aspirate examination. So the two DDs that we have here are gout and pseudogout. Now your septic arthritis and osteoarthritis would be ruled out itself since osteoarthritis ke liye, we have the history of like stiffness and pain after some activity done, and for septic arthritis it occurs in most commonly in children and it is associated with fever and all those things, so these are ruled out. And then moving to gout and pseudo gout, if we have a diagnosis, so for gout and pseudo gout, now the question is clearly saying that the swelling is in swelling and pain in the knee joint. So knee joint is commonly associated with pseudogout. Okay. Also, it is saying positively birefringent rhomboid shaped crystal. So the answer is pseudogout here because we know for gout is negative. So gout is negative. Gout ke liye we have negatively birefringent. Gout के लिए we have negatively birefringent needle shaped crystals. Needle shaped, in contrast to what we have for pseudogout. For pseudogout we have positively birefringent. And for P we can remember it as parallelogram. Okay, so it is, we can remember it as parallelograms. P for P, so it is rhomboid shaped, positively birefringent. So in first question your answer is pseudogout. Now moving to the next question. A 7-year-old boy falls on his outstretched hand and sustains a supracondylar fracture of humerus. So it is the history of Fuchs is given, and it is the given that supracondylar humerus fracture is happening. Then he is unable to make the OK sign. Unable to make the OK sign is Killow-Nevin sign. Okay, it is Killow-Nevin sign due to the weakness of FPL and FDP. So which nerve is most likely? The AIN is most likely. Now our next topic is supracondylar humerus fracture. Okay, so about the supracondylar humerus fracture, about that, there are two types of supracondylar humerus fracture. Okay, so first of all, it is the most common fracture in children, most common elbow fracture in children. Then it is usually due to fall on an outstretched hand. So it is usually Fuchs. Then it is of two types, extension type and flexion type. Extension type being the most common one, manifests in 95% of the cases, in contrast to flexion type, which is only 5% of the cases. Now the classification used for SCH type fracture is Gartland classification. It is Gartland. We can remember is that the Gartland that we used. Then the clinical features are S-shaped deformity at elbow. So this is not a very important point, S-shaped deformity at elbow, because no question is asked from here. Now the complication part is very important, that the early complications include the nerve injuries. Okay, so you know that most common type of nerve injury is AIN, but other nerve injuries can also be involved, like medial, radial and ulnar. So we remember it with the mnemonic AMRU. Okay, so now for anteromedial displacement, median nerve is involved. For posterolateral displacement, radial nerve is involved. And for flexion type, your ulnar nerve is involved. So since we know the flexion type is the least common one, so the ulnar nerve is least commonly involved here. Okay, so this is how we can know that the ulnar nerve is going to be least commonly involved. Now, one of the most common late manifestation, late complications are malunion. Now, malunion leads to gunstock deformity, and the gunstock deformity is also known as cubitus varus. The gunstock deformity is also known as cubitus varus, and the angle used here is Bowman's angle. We can remember Bowman's angle as Bahubali. So the garland is used to like make wear to the Bahubali. So this is how we can remember the Bowman's angle. Now the Bowman's angle is formed between humeral shaft and growth plate of lateral condyle. And growth plate of lateral condyle. Okay, so for treatment we have close reduction and tunnel fixation with K wires. Now we are going to cover the most important exam points for supracondylar humerus fracture. So most important key exam points. Now your key exam points are most common type. Most common type is extension type. I told you earlier also it manifests in the 95% of the cases. Then most common nerve injured. Most common nerve injured is AIN, which is the motor branch of median nerve. Motor branch of median nerve. Then your most dangerous complication. Most dangerous complication is Workman's ischemia. Then the most common late complication. Most common late is cubitus varus. And the gunstock deformity is due to malunion, also known as cubitus varus. So malunion. And the sequence in which various nerves are involved is AMRU. That is AIN, median, radian, ulnar. Okay, so this is all about the supracondylar humerus fracture that you have to remember for the exams. These are the all important key points. So 2 questions are covered here. Now moving to the next question. The next question is saying that a 67-year-old patient with unclear medical history present with swelling around the left ankle with a chronic non-healing foot ulcer on examination reveals movements beyond the limits and a loose bag of bones are felt at the joint. What is the most likely pathology? So rheumatoid arthritis, we know that it is completely not going with the history, so we will rule it out. Also, the chronic non-healing foot ulcer gives us a clue of diabetes. Okay, so it gives us a clue of diabetes where vascular and neurological compromise can be there. So that's why the foot ulcer is not getting healed. Okay, so when there's a clue of diabetes, also these loose bag of bones points towards the Charcot joints. So these are Charcot joints. So that's why the answer is Charcot arthropathy. Okay. Also, we know that it cannot be rheumatoid arthritis. It is involved with small joints like PIP and MCP, and all the morning stiffness history is there. So this is can be definitely ruled out. Then septic arthritis most common in children, associated with fever and pain and all those things. So this is also ruled out. So C is our answer here. Then moving to the next question. A 12-year-old boy presents with a pain in the elbow joint that worsens with activity. X-ray shows a localized lesion involving the capitellum of humerus with a small fragment sudden separating from the subchondral bone. This condition is an example of which of the following? Osteochondritis. So this is the topic of osteochondritis that we have to cover here. So simply we have to know that the capitellum of humerus osteochondritis is what? So the capitellum of humerus osteochondritis is Panner's disease. Okay, so now we have to come to the topic osteochondritis. So for osteochondritis, we have to remember the eponyms, the important eponyms on osteochondritis. Okay, so osteochondritis. Now, osteochondritis is due to the ischemic necrosis of ossification centers. Ischemic necrosis of ossification centers. Now, first for capitulum of humerus, we have done it in the question itself. It's Panner's disease. Panner's. Then for head of femur, it's Perthes disease. Perthes disease is a very important one, and we are going to discuss it in further questions ahead. Okay. Now for navicular, it's Kohler. So we can remember it as navicular Kohler. Okay, this can be used as a mnemonic to remember it. Then fourth one is calcaneum. For calcaneum, we have Severs. Then for tibial tuberosity, we have Osgood-Schlatter's disease. Osgood-Schlatter's for tibial tuberosity. And then inferior pole of patella. For inferior pole of patella, we have Sinding-Larsen Johansson syndrome. For second metatarsal head, we have Freiberg's disease. Second metatarsal head, Freiberg's disease. For lunate, we have Kienbock. And this is all. These are the important ones that we have to remember here. Okay. Now, for Perthes disease, is important to remember. This is an important one that it presents in the typical age of 4 to 8 years. Painless limping is present there. So all these things we are going to cover in the further questions ahead. Now moving to the next question. The next question is a 13-year-old boy presents with fever, pain, swelling over the mid shaft of the femur. So the mid shaft is telling us that the location is diaphyseal. There is a local warmth and tenderness. Laboratory evaluation shows leukocytosis and elevated ESR. X-ray of the femur shows a destruction in the diaphyseal region with periosteal reaction. Okay, so the diaphyseal tumor that mimics the osteomyelitis, it is mimicking the condition of osteomyelitis by warmth and the elevated ESR and all those things. So it is Ewing sarcoma. It is pointing towards the diagnosis of Ewing sarcoma. Okay, which is very common in this 13-year-old age boy group. Now, from the histological image, we can see that the histological characteristics of Ewing sarcoma is this small round blue cells with homocyte rosettes. So here this image has been given as a clue to you. This won't be given in the exam. So we have given it as a clue. So the periosteal reaction for Ewing sarcoma is onion peel like. Onion peel periosteal reaction. Then moving to the next question ahead. A 32-year-old postpartum woman complains of pain and swelling over the radial side of the wrist, worsened on thumb movements. On performing Finkelstein test, the pain is reproduced. Which tendon is inflamed in this condition? Now the Finkelstein test is a characteristic for De Quervain's tenosynovitis. So it is for De Quervain's tenosynovitis. Now in this test, what we do is we ask the patient to make a to we ask the patient to make a here what do we do is we ask the patient to make a fist. Okay, in for Finkelstein's test, we ask to make the patient a fist in which the thumb lies inside. Okay, so in the fist, the thumb would lie inside. Thumb lies inside, and we ask the patient to deviate the fist ulnarly, like medially. We ask the patient to navigate the wrist, and then the pain is referred to the radial styloid process. Pain in radial styloid process. So the tendons that the decurving stenosynovitis involves inflammation of the tendons, abductor pollicis longus and extensor pollicis brevis. It involves inflammation of the tendons APL and EPB. Okay, so this is your characteristics for decurving stenosynovitis. And the pain and swelling over the radial side of the wrist, that is the radial styloid process, is the hallmark for this decurving stenosynovitis and Finkelstein's test. So this is it with this question. Now moving ahead, we have 65-year-old women presents with progressive knee pain, stiffness after rest. Okay, progressive knee pain, stiffness after rest. So rheumatoid arthritis would be absolutely ruled out, since rheumatoid arthritis is involved with the inflammation and pain in the small joints like MCP and PIP. So it involves MCP and PIP bilaterally symmetrical, early in the morning, not after rest. Okay, so stiffness after rest is for, and progressive knee pain is for characteristically for osteoarthritis and not for rheumatoid arthritis. For psoriatic arthritis, the X-ray would show pencil and cup deformity. Pencil in cup. And for gouty, the first metatarsobpharyngeal joint is involved most commonly. So the clinical history that is given here, the joint space showing narrowing and the osteophytes and subchondral sclerosis, involvement of knee joint, okay, and involvement of distal interphalangeal joint. Then this distal interphalangeal joint involvement is Herbeden nodules. So this is Herbeden. And for PIP, we have Borchards nodes. So this is characteristic of osteoarthritis. So this is the answer here. Then moving to the next question. The next question says that the patient presents with weakness of shoulder abduction. Now for shoulder abduction, we know the muscles involved are supraspinatus, then your deltoid. Okay, then deltoid for 15 to 90 degree, supraspinatus for initiation, and serratus anterior for overhead abduction. Okay, serratus anterior for overhead abduction. So these three muscles are involved here. So these three account for the DD of the muscles involved. Now the clinical test shown in the image, it is a empty can test. So this image is for your empty can test. So this is empty can test, also known as Job's test. This is also known as Job's test. So this is for supraspinatus. Now moving on to the next question. What we have for the next question is, which of the following statements about hip dislocation is false? Now your posterior dislocation is more common than anterior dislocation. This is the correct statement. So the posterior ones are most common with the dashboard injury. These ones are most common with the dashboard injury. Okay, now the posterior dislocation flexed adducted, and for posterior we have father. We have father for posterior hip dislocation. So flexion, adduction, and internal rotation is for posterior dislocation of hip. Then sciatic nerve injury is more common in posterior hip dislocation. And then the vascular injury, that is the femoral artery, is more common in anterior dislocation of hip. It is more common in anterior dislocation of hip. Now your option D is the incorrect one here, since it is not managed conservatively without reduction. Reduction has to be done here for posterior or anterior dislocation. So D is the answer here, which one of the false. Okay. Now for posterior dislocation, we also have shortening and internal rotation. The shortening of limb is also associated with posterior dislocation. So it can be remembered by the mnemonics SIR, shortened and internally rotated limb. Okay, so done with this question. Moving on to the next one. We have here a 22-year-old male with severe pain at night in tibia relieved by aspirin. Radiolucinitis with sclerotic margin. This is characteristic of osteoid osteoma. And the treatment done here is RFA. That is your radiofrequency ablation. So this is also one of your PYQs. And pain at night relieved by aspirin, then the small radiolucent niacin showing this sclerotic margin is all the history is very characteristic of osteoid osteoma, and the treatment is RFA. Okay, so moving on to the next question. Young cricketer develops lateral elbow pain worsened on resisted wrist extension. Worse on resisted wrist extension is a hallmark for lateral epicondylitis. So this is the hallmark for lateral epicondylitis. It is also known as now the medial one is also known as golfer's elbow. And for lateral epicondylitis, it is also known as this is also known as tennis elbow. So your we played tennis, so we can remember it as we played tennis with our cousins. So the test done for this lateral epicondylitis is called Cousin's test. Okay, so lateral elbow pain worse on resistant wrist extension is a very classical for lateral epicondylitis. So B is the answer here. Now moving to the next question. A 60-year-old male has progressive deafness, both tibia, elevated ALP. The X-ray shows cortical thickening and mixed sclerotic lesion, most likely diagnosis. Now the ALP is elevated when all the other biochemical markers are normal. Okay, all the other biochemical markers normal and ALP elevated is characteristic for Paget's disease. It also comes with a history of progressive increasing in this heart size. Okay, now in contrast to this, completely opposite to that is multiple myeloma, where ALP is normal and all other biochemical markers are deranged. Cold spot on bone scan is saying no new bone formation. No new bone formation. So this is completely opposite for multiple myeloma. And for osteoporosis, we have all the biochemical markers normal. All are normal. So this is for osteoporosis. Now moving to the next question. A 10-year-old boy presents with painless limb and the X-ray shows fragmentation and collapse of femoral head. So this is very classical of Perthes disease. Since Perthes disease, 4 to 8 years of age is classical. And then it is also associated with painless limb. For SEFE, it is not associated with painless limb. There is pain present. So SEFE can be ruled out. And then your developmental dysplasia of hip is present in infants or young children. and associated with waddling gait, and then the limb and this discrepancy in the limb and up body and this length, and then the osteomyelitis is associated with fever and increased ASR and all those things, sepsis, and so that's why the osteomyelitis is also ruled out. Then a young athlete presents with knee pain after sudden deceleration and twisting injury, then pop sound is heard, knee swelled within 1 hour, that is very early, and Latchman test is positive. Now Latchman test positive Latchman test is for ACL injury. It's for ACL injury, and we can remember it as this. LAC is for ACL. Latchman LAC is for ACL. Okay, Latchman test is for ACL. Then the pop sound is also very characteristic of ACL. Then this swelling within 1 hour is also ACL. For meniscal tear, the swelling takes place later, that is from 6 to 24 hours. Okay, so for meniscal tear, the swelling takes place later at 12 to 64 hours. Then for PCL, we have posterior drawer test. For PCL, we have posterior drawer test associated with dashboard injury. And for meniscal tear, we have McMurray's test and Thalasie's test. McMurray's and Thalasie's test. Okay, so ACL is your answer here, since the characteristic pop sound swelling within 1 hour, and then the Latchman test being positive. So this is what ACL. So this is your answer here, and this is all we have done with all the questions. I have not counted exactly how many, but we have done with all the important questions that we had today here for you all, guys. So these are the important ones and the important topics for the November INI. So thank you and have a nice day, and do subscribe and click on the bell icon to be notified further, and stay tuned and subscribe for more, and don't forget to like and share if you like it. Okay, so bye bye and take care.